On-the-scene video coverage of TCT 2012 is supported by Pradaxa.
So thank you for the opportunity to present our results here in the press conference, the results of the cardiac magnetic resonance sub-study of the AIDA STEMI trial. So the study was supported by an unrestricted grant by Lilly, Germany, the University of Leipzig, and supported by the Federal Ministry of Education and Research in Germany. So we studied whether intracoronary bolus administration of Abciximab as compared to intravenous bolus administration of Abciximab is superior regarding clinical events. You see here the total population, which we have recently published in the Lancet, 2,065 patients, and we were not able to discriminate that intracoronary bolus administration of Abciximab is superior to intravenous bolus administration with respect to a clinical endpoint: death, reinfarction, and new congestive heart failure. But we looked also in the single components of this primary endpoint, and we found that the occurrence of new congestive heart failure was significantly lower in the intracoronary group as compared to the intravenous group, and this may be a result of a reduction in myocardial infarction. So we have given the bolus of the Abciximab, which is a glycoprotein 2B3A inhibitor, via the guiding catheter, and if you measure the blockage of the GP2B3A receptor on the platelets in the blood coronary sinus, this is higher, at least during the first pass of this administration. And our hypothesis was that with this high local concentration, there may be a faster and a higher degree of platelet disaggregation at the target lesion in patients with acute coronary syndrome, but also in the microvasculature, and this may result in a reduction in myocardial infarct size. So in this study, we used cardiac magnetic resonance imaging, and this is the largest trial up to date using cardiac magnetic resonance imaging in patients with ST elevation myocardial infarction, almost 800 patients. And this magnetic resonance imaging enables the investigation of the mechanistics and pathophysiological effects of intracoronary compared to intravenous Abciximab application on myocardial damage and reperfusion injury. And we performed this sub-study to determine potential benefits of intracoronary Abciximab application on infarct size, myocardial salvage, microvascular obstruction, and ventricular function, and to further evaluate the benefit with respect to congestive heart failure. So this study was performed in Germany, and 22 sites took part in the total study, and 8 centers included all of the patients if there was no contraindication for cardiac magnetic resonance imaging to the cardiac magnetic resonance imaging sub-study. We had a clinical event committee, a data safety monitoring board, and in these patients we had a detailed MRI protocol which allowed us to get all the images within 40 minutes. And we were able to assess the area at risk, which is edema, plus hemorrhage in T2 weighted images. We were able to assess the left ventricular function, the left ventricular volumes, and in delayed enhancement we were able to assess late microvascular obstruction as well as the infarct size. So 394 patients were randomized to the intracoronary bolus Abciximab administration and 401 to the intravenous group, and both groups received the standard 12 hours infusion by the intravenous route of administration. There were no differences in the baseline characteristics. About 20% of the patients had diabetes mellitus, and about 50% of the patients had anterior myocardial infarction. So the area at risk was quite high, so we had in median 35% at risk of the left ventricular muscle mass in both groups, and the infarct size unfortunately did not differ between both groups, so we had in median 16% with the intracoronary administration and 17% with the intravenous administration, and the same for the other characteristics. No difference in microvascular obstruction, no difference in hemorrhage, and we also did not observe a difference in left ventricular function. This subgroup analysis did not show that there was a benefit for any of the subgroups with respect to infarct size, including patients at high risk with anterior myocardial infarction and those with a short time difference between symptom onset and randomization. We also looked, this is the largest MRI trial with STEMI patients, in patients without MACE and those with MACE regarding the differences in the MRI parameters. And we were able to see that the infarct size was significantly smaller in patients without MACE, that the myocardial salvage index was significantly higher, and the LV ejection fraction was also significantly higher in patients without MACE. So in summary, this largest multicenter MRI study in STEMI patients to date demonstrated that the intracoronary as compared to intravenous bolus administration of Abciximab did not result in a difference in myocardial damage and or reperfusion injury, and the results of the AIDA STEMI CMR substudy therefore confirm the lack of difference in the combined endpoint of death, reinfarction, or congestive heart failure of the AIDA STEMI trial. Thank you.
Great, thanks so much. Any questions from the press? Alice, what are your thoughts?
Well, this was nicely done, and I think it sort of completes your trial now. The results, I would think, were what you anticipated, since you didn't show any difference in the overall trial in CK and flow, I think, as I remember last year, and ST segment resolution. So this confirms it. I think the overall trial was discussed last year, reasons for that you didn't show the anticipated difference. The event rate was smaller than anticipated, as I remember. The intravenous bolus could circulate quickly. It was given via the guide rather than distally, so there were those issues. But I think this very nicely and neatly puts it all together.
Any thoughts on the use of the MRI as an endpoint? I mean, this is the largest MRI study. There are some people that believe that the early MRI may differ from the late MRI just because edema can resolve. Is this something that we can use now? Because it's harder and harder to do trials now. Is this an endpoint that's valid?
I think we have, yes, it's a valid endpoint because we have shown in this largest MRI trial that it is important to reduce the size of myocardial infarction. Patients without MACE had a significantly lower myocardial infarct size determined by MRI. And we have recently seen two other trials with the MRI endpoints, which is the INFUSE AMI trial presented by Greg Stone at the ACC, showing that with intracoronary Abciximab via a clearway catheter locally at the target lesion, that with this treatment approach there was a significant reduction of myocardial infarct size at 30 days MRI. And we have yesterday heard the results of the master trial of a subgroup of patients with MRI, that with the MGuard, a mesh-covered stent, that this MGuard stent, there was also a trend towards a lower myocardial infarct size as compared to the standard treatment. So I think it's really important to have those trials and to look that we get therapies to reduce myocardial infarct size, which translates into a better clinical outcome in our patients.
I think that's right. Any questions? No questions from the call-in line? Okay, great. Thank you.
Thank you.